So some of the safety data. This is a paper that came out of Cleveland, Dr. Gonzalez Martinez, and they've done, I think, the most SEEG in the states that I'm aware of right now. And this paper kind of looked at the safety of SEEG in general, and also particularly with the robot assisted, and they used the ROSA there. They were able to compare it to their historical cohort. They looked at about 1,200 electrodes placed in about 100 patients. Most of those went for resective surgery based on the results. You can see the accuracy was within 1 to 2 millimeters in reaching their target and their entry points. They had, of those 1,245 electrodes, they had 4 major complications, only one of which was symptomatic, but it did lead to death, which comes out to a 0.08% risk of a major complication per electrode. Whenever we plan these cases, we always get vascular imaging out of that concern for hitting a blood vessel. It's very rare. I think 0.08% risk of major complication is better than the risk of complications associated with just putting grids on the brain. And you have to do a big craniotomy and then have all these wires coming out the scalp and the risk of CSF leak and stuff. We found this to be much better tolerated and very safe. Let's see. In children too, the same group in Cleveland looked specifically at their experience with SEEG in children, again showing similar type results and similar safety. Slightly higher risk per complication, may just be in numbers, but they 0.2% risk of complication per electrode.
How about children under 5?
I think they've done it up to the age 2, but I don't know the risk of complications.
Yeah.
I mean, as a pediatric neurosurgeon, are you worried about the thinner skulls and some of the obviously infants and younger?
Yeah, I would be worried mostly. I would do somebody under 5. I would be worried once you start looking under about 2, 3, when the skulls are really thin. Even in older kids, 5 and up, when you start placing the bolts down in the lower temporal region through the squamous bone, it's pretty thin there. We had a case just recently where we couldn't get the bolt to engage and into the skull, and so then we just placed the electrode using our stereotaxy with the robot, and then stitched instead of having the bolt secure it, we just stitched that single electrode to the skin as it came out, and it worked.
Okay.
Were these cases that were the pediatric ones, were these any of them ECOG, or were all of them long-term monitoring?
Well, in this paper, it was done at, I think these were all for long-term monitoring. Yeah, all these are for long-term. It's hard to do like an intraoperative ECOG, like if you're doing a surgical resection and you just want to put a depth electrode in. The ROSA is not very useful for that, actually. You could, I suppose you could, but the robot would kind of be in your way. If we're placing a depth electrode intraoperatively during like a resection, usually I'll use Brain Lab or something for that.
But I do ECOG when we do implant, just to make sure that all the electrodes are recording well. And it's really more like a 5-10 second per electrode to see what it looks like, and then just takes like it ends up to be like a 3-minute ECOG, pretty much.
Yeah, make sure we get good readings from all the
that there's no faulty electrode or anything like that.
Okay.
This is one more paper from the Cleveland group where they kind of show their strategy, and here you can kind of see what I was talking about earlier, how they place all their electrodes in this parallel and orthogonal to the sagittal plane. They strategize their placements to be able to look for networks. We've gone on to adopt more of this strategy in placing our SEEG loads, just mostly for the ease of reading the results afterwards. The exception, I would say, is in their paper they describe kind of hitting the insula, just shooting straight through the Sylvian fissure. I'm always a little nervous putting electrodes through the Sylvian fissure with all the vasculature that's there. And also when you hit the insula doing that way, you really just get 1 or 2 electrodes in the insula in one isolated spot. It's hard to interpret that. We're now coming from above to put the electrodes into the insula where they can run lengthwise from superior to inferior to be able to read those. So that would be our exception to placing the electrodes in a parallel to the orthogonal plane.